Since the end of a COVID-19 declaration, we have been seeing on average 3 COVID positive. Just a reminder, if you do test positive, you stay home for 5 days. On day number 5, you test yourself. And if you still testing positive, you stay home for an additional 5 days, so that's a total of 10 days. But if you test negative on day 5, you have no symptom for 24 hours, then you can come back to work on after day 5, so that would be on day number 6 if you are scheduled to work. Okay. That's it for COVID. And what do I want to do? What I do want to address is the new transmission-based precaution, enhanced standard precaution. I would like to roll this out facility-wide. When I say facility-wide, it just means us, the SNF. But this is strictly for SNF. I would like to start this on Monday, but I want to communicate this with you because you are the nurses who's going to be on the floor. The CNA is going to come to you and ask you a question. Yeah, come on.
Yes, I can see it on that phone.
Yeah. Hey, John, you can sit right here.
The CNA is going to come and ask you a question because, I'm not going to always be here every single day, every evening, every weekend. John probably might not be here, so I want the nurse is going to come, the CNA is going to come to you guys. So I want you to be familiar with what enhanced standard precaution is. We always see contact precaution, airborne, and droplet. And the newest precaution, it's the enhanced barrier precaution. This is the CDC's precaution.
No, I'm thinking about it.
So California adopted this guidance, but California dropped the barrier and put standard precaution, enhanced standard precaution. So we're gonna start seeing this on residents' doors starting Monday. Currently we have 2 residents under MDRO. That is currently our pilot program, but on Monday we're gonna introduce this facility right. So expect to see this on the door. So I just want to let you guys know that, so anybody who has history of MDRO, whether it's active or whether it's colonized, we need to gown and glove for those residents. A residents with a pressure sore, a chronic pressure sore that has not healed it has been over 6 weeks now and it hasn't healed. If I'm providing treatment or if the floor nurse is providing treatment to that resident, we need to gown and glove. The only time you will not need to gown and glove is if you just, you're just getting the resident's undressed, taking her to the restroom. But because she has a pressure sore, then you will need to gown and glove. For a CNA, they do not need to gown and glove. It's only if you're providing wound treatment. Okay. A resident with indwelling devices, meaning a foreign object that's inserted into your body, such as an IV, a PICC line, a feeding tube. We used to have feeding tube, but it's been a while since we have feeding tube, tracheostomy tube, Foley catheter, suprapubic, all those foreign devices going to a person's body, we need to gown and glove. So for a resident with an IV, CNA is going into that room, getting that resident's dressed. He or she does not need to gown and glove. The only time you're gonna gown and glove for a resident with an IV or a PICC line is if you're providing care, which is administering medication through that IV line, or removing that dressing. That is when you need to gown and glove. So you talk about the pressure sores, IV. For Foley catheter, same thing. If you're providing care, first thing in the morning, you're getting that resident up and dressed. You're gonna be handling that bag. You need to gown and glove because it can create splashing. We are stuck with this. If it causes splashing, we're stuck with this scrub. We can't remove it and put on a new scrub. And if I decide to give a resident a hug, I can easily spread that germs to a resident's where for us, if I'm exposed to it, I may not get sick from it, but for residents who are immunocompromised, they can get sick. So that's the reason for gowning and gloving when you're working with a resident with a Foley catheter. And CNA, who is working with these residents, they'll also need to gown and glove during shower. So during shower, CNA need to gown and glove also, because you think about it, you have someone with the Foley catheter, you know, you open and close it, it drips. We handling the bag. Once the water touches the bag, it goes, you know, it touches the floor, it remains stagnant on the floor. And then after the shower, we need to communicate with housekeeping to sanitize the bathroom before the next residents come in. I already communicated with housekeeping, maintenance, pretty much the whole team, including the dietary. I already have an in-service, so they're all aware of the new precaution, which is enhanced standard precaution.
Okay.
Yes.
Would there be any supply in the bathroom or the
Yes,
shower
yes,
room?
yes. Starting tomorrow, I'm gonna go to room, the residents that needs them. The PPE gown is gonna be inside the closet next to the brief. Because, you know, they're asking us to put a cart outside.
Yeah, I said, are we gonna have a cart out of every room that everybody in a pick line or a Foley?
No,
Are we gonna have a cart,
I'm gonna put it inside.
or just the?
You're gonna have this sign
appliance inside
on the
the-
door, and then the gown is gonna be inside the closet.
But no cart.
No, I don't want any cart, because, the enhanced standard precaution, we have a few residents who's gonna be on this for a lifetime.
Yeah.
And the last thing I want is to have cart outside, because having this sign can, you know, it's like a target.
Sure.
Let me see what it looks like, Sam. Okay.
It's a target. When visitors come in, we have Medicare visitors that come in and out. They see the sign, they're gonna start asking, how come there's a cart out there? How come there's a sign out there? And then once we explain to them why the residents are under this precaution, the last thing I want is for the family member to say, no, I do not want my mom to sit with that so-and-so, because he or she can potentially spread germs. Gown can be found in the residence closet, and I'm also gonna put gowns in the shower room, in the cabinet. Remember, this is not a contact precaution, it's not an isolation precaution, it's a enhanced standard precaution. You know, standard, what does standard mean? You know, it's universal. If someone was blowing their nose and a resident hand you a tissue, you don't touch it with your bare hand. The universal standard precaution is put on a glove and you throw it away. So that's what it is. It's not a contact, it's not isolation. Residents may come out to the dining room, but you know, we need to do a better job before going into meal, provide hand hygiene for the residents. Visitors can come in and visit those residents under enhanced precaution. The only time a visitor will need to wear a gown or glove if they were doing high contact care with the residents, which they should not be doing. You know, they shouldn't be taking the residents to their restroom, or let's say their loved one. That's our responsibility. So visitors can go in, but then we just have to educate them that before you enter, hand hygiene, before you leave, hand hygiene. Any question?
Alright,
How
so
long are they gonna be on isolation? Somebody has MDRO and they've had it for years.
Yeah,
Are they
that-
gonna still be on it forever?
Yes,
Until they pass
it's
away?
forever.
Until they
Yes,
leave?
it's forever.
So we gotta do it
I sent
forever.
out an email to confirm.
Yeah.
They said yes, regardless of the infection status, they need to be on it forever.
That
And
includes everything else.
yes, and then I also reached out a question about wound care and IV care. Because initially I thought we have to wear it all the time but it's just during, if you're doing wound care and you're providing treatment, then you need to wear a gown and glove. But if you're not doing wound care, then there's no need. And I save all that email, just in case a surveyor comes in and asks why you're not wearing a gown and glove all the time. Because what John and I learned during COVID, you automatically assume that surveyor knows everything, but in reality, they just learning just like us. So, like John and I would disagree and say, hey, no, that's not right. It's 10 days isolation, not 21 days. That's a long time ago. So that's what I learned. So every time I communicate with somebody, I like to save it, so just in case someone, somebody asks, why are you doing this, you're doing it wrong, I have my proof right here. I've already reached out to a couple people and they all say the same thing.
You're gonna be in a room
Take,
by
take
themselves.
a look at this.
Or
Alright.
with somebody with the same
Yeah,
problem.
cohorting with the same infection.
So we gotta be careful on what admissions we take, because we might not have
Yeah.
the space for them.
Yeah, so if you have a resident with a Foley catheter, it's best to put that resident with a Foley
Or not take
catheter.
them at all.
Okay, Sam did a really good job of talking about this infection control process. I'm gonna throw in a little, like I paint a little picture for you, okay? I'm gonna put an example out there. Your patient comes in with MDRO, multi-drug resistant organism in the urine, right? This is the same bacteria that causes the same UTI for another resident, maybe, down the other hallway, right? Except this one is multi-drug resistant, right? That means that there may be only one medication that's going to be effective for this resident with this infection, okay? When they come in and they're still on antibiotics and they're still symptomatic, they're going to be likely on contact precaution, right? They're still in contact, and you're going to do your infection control process is going to be more significant than the enhanced, okay? 7 days later, 10 days later, a year later, 20 years later, right? They still have that MDRO. They're going to be in enhanced precaution, as Sam has said, right? That means that even if they don't have Foley catheter, but they have a history of MDRO, they're going to be on enhanced precaution. If you're dealing with urine, you're dealing with Foley catheter, you're going to put gloves and gowns. Gloves and gowns are going to be your main thing with MDRO, okay? So does that make sense? Somebody comes in with an infection, it's not enhanced precaution, it's whatever precaution that may be, and it may be higher than enhanced, okay? You have airborne, you have droplet, you have contact, and you have enhanced down here, but enhanced you can apply for all your residents that may be either a high risk for MDRO or already has a history of MDRO, okay? So like he said, if you have a wound that hasn't healed in more than 6 weeks, which is now a chronic wound, that person is enhanced, right?
Mm-hmm.
That's enhanced. A person who doesn't have MDRO but has a Foley catheter, that's enhanced, right? So those are just example. As we move through, when we have this rolled out on Monday, we're gonna talk about it more. But as nurses, we're gonna have to explain this to our family members, residents, and especially your CNAs. Okay.
Just one thing, I already reached out to the family members who's gonna be under enhanced, and they all agree, and they all understand.
Okay. Any questions on infection control, enhanced barrier precaution? We have a young lady here from dietitian, and she's gonna talk about anything dietary. So you got a question with her as far as dietary, but she's also gonna. Thank you, Sam. She's also gonna talk about some issues that we have.
Hi, I'm Shelly. I'm the dietitian.
Do you mind if I record you?
Go for it. Thanks for
Thank
asking. I'm taking over for Erica until she's back in October. So yeah, if you have any dietary questions, please let me know. So what I wanted to talk about is weights. There has been an issue with one about collecting weights during admission. So really important that we get their admission weights, because after admission, like after, let's say they're on their fluid overload, whatever, like we need that earliest weight to compare it to the next day. So if we take it the next day, it's already we can't compare. So really important. I know we say, I think someone told me it's 24 hours, but really if we can get it in as soon as possible, that would be great. Weight and height, I've noticed, sometimes I see residents that don't have any weights after being here for like 4 days, and that's definitely like not okay. So if we can work on that and get the CNAs to work on that too, that would be great. I do my weight variant it starts every Sunday. So really important that we get those weekly and monthly weights like on time. That way they can be in my report, because otherwise they don't get triggered. So like, let's say even if you do it on Monday, they won't get triggered. So really important that we follow that. And I know it's kind of hard, like I know one resident right now has a really random like weight collection, which it's like Mondays and Fridays. So I know it's really random and we don't see that often, but if we can really just make sure to keep an eye on that, and make sure we're collecting the weights during those times, because this resident specifically had some issues and I needed to observe it, and when I went back I didn't have any weights, and so then it's hard for me to do what I'm supposed to do. Yeah, and that's it for weights. Do you guys, anyone have any questions?
I have a question.
Yeah.
We're always told, Erica always told us on the evening shift to not get the weights when they come in because of the time, because it's not gonna be accurate. First morning weights are always accurate, and she said they're not gonna be accurate. So if we do a weight at 7 o'clock at night, and then we do it at 8 o'clock in the morning, it's gonna be different. So Erica always says, just do it the next day. She does never order us to do it in the evening.
So yes and no, I agree.
I
If
disagree.
we can get weights in the morning, once they're here, yes, but I do want you guys to get their weights.
Baseline.
when-
You wanna get
when
the
they're
baseline.
here.
No matter what time.
Exactly, because in that time, during that night, a lot can change. So it's really important to have it specifically admission weight, and that's something I refer a lot to when I compare their weights and like see what's going on with them in my assessment. So really, really important that we get admission weight, and then actually that's a really good policy, you know, when they're here later in the afternoon, do a weight when they get here, and then do one in the morning too.
It's our policy, guys. It's our admission policy to get the weight. So we need to get that weight.
If you look on the admission template, it always is for the next day. So,
The weight?
yes, it's not
Yeah,
for this day.
because
If I have an
sometimes
issue,
they have a,
no, I'm not
surgical,
for the next
you know,
day.
procedure,
'Cause
and
Erica
they don't wanna
always
be
told us to
moved.
get it in the morning.
That's true. But we have a lot of machines that we have implemented to get the weight.
You have to
Yeah.
talk
Oh,
to
we
the
can change
RNA
it.
about it, because I had an issue with the RNA
Yeah,
about
I
that.
think I know it's hard sometimes, especially because like I'm here and then like Erica has been here for years. But in my clinical experience, I think that it's really, really important. It's like as you guys know, it's called a dry weight, right? So when they come here, they get all this fluids taken out, whatever, and then they come here and then we are able to collect their driest weight. So within that overnight, their fluid overload can change by a lot, right? So that's the difference there. So I do understand like there's policies and other people do things this way, but like at the end of the day, we have to use our clinical judgment, and here the clinical judgment for me is saying that, especially for the residents that have like fluid overload like issues and like weight gain, you know, like all that, really important, you know, just like, yeah, so.
And so I'm going to remind everybody too, we are a skilled nursing facility. If somebody has a hip fracture, you can certainly get them up, get their weight and lay them down. And we're not saying walk them 10 feet, 2 feet even. We're just saying stand them up and get the weight. We can do log roll.
Yeah.
There's a certain technique that we know that we learned in school. And we can do these weights in bed, either Hoyer lifts if they have whatever, that they can't stand up. Or you can do 2-person, right? Get them up. I already bought and purchased, not me personally, but we purchased the in-room scale so we can take these weight.
Is it a chair
So it's a
scale or
baseline
not?
weight is really important.
Yeah.
Yes, ma'am.
Can you, in service the RNA
The
about
RNA,
it, you
okay.
know, because they're the
Oh, the one
that's
that-
doing
the PM RNA?
Yeah,
Okay,
the weights,
okay.
and whenever we tell them about the
And
weights,
so-
they said that, we cannot touch them because physical therapy has to evaluate them first before we,
That's
we
a
do
yes and a
something,
no.
you know.
It's evaluation for ambulation, not
Yeah.
for weight, not
I
when
know,
taking weights.
But that's what they always say, so
Okay,
if
I'll-
you know.
Thank you for bringing that up. I
Yeah.
will bring that up.
It sounds just like a miscommunication that we should like clear out between everyone.
Yeah, I always tell them to weigh them right away, but that's what they
We
tell
do
me.
need to clear that up, Shelley,
Sure.
because
Yeah.
there is other policy also
Yeah.
for our CNAs can't
Yeah.
move these patients, especially
Yeah.
ortho patients,
Right.
Yeah.
without a PT eval first.
Okay.
And
And
some
I
of them
understand
refuse.
what you're talking about, dry weight and stuff like that,
Yeah.
but to me,
Yeah.
like, if somebody gets in at 7 o'clock, I'm not sure what you do with, because part
Yeah.
They don't
of
wanna
the
be
weight
moved.
variance is to get it at the same time
Right.
before breakfast, so, and they may already be fluid overloaded because they just got off IV,
Yeah.
hydration or something. So I don't necessarily wanna put more work on the PM shift, which has less staff. You see what I'm saying? I'm not sure how, I mean, I almost feel like saying, Shelley, just please look at the weights from the hospital, because it's gonna be so
Yeah.
different. And given the PT eval and all that stuff, I don't wanna tell my staff,
Yeah.
because that's just one additional thing
Right.
that may not get done. I understand, I heard you about like 4 days not getting done.
Yeah.
That's not acceptable. Somebody
Right.
should get in my opinion, a base weight the first morning before breakfast, and that should be the base.
But here I can explain why it doesn't get taken in 4 days. Okay, if you don't take it on the admission weight, I guarantee you it's not going to be taken unless a week later when the order says take the order a week later.
Then we
Nobody's
need to
going to follow up the
then we
following
need to
day.
change
That's why the
order.
policy is always about taking the
But then
weight
we need to
right at
change
primary.
the order so that it's like the next morning, whatever.
We got to
before
change the whole
breakfast.
policy because on the policy it says take your
Then-
weight
then
upon
we change
admission.
the policy, because the policy as of right now doesn't make
Can
sense.
I say something? The hospital beds, the reason they always keep up their weight because their beds equipped with a scale. So that's why it's easier for them to take weight. But sometimes we get the residents who are like non-weight bearing status, and we can't really like move them. So it's for us it's a liability, and we don't have beds that have scale.
And I do kind of want to answer like for both of you guys. This is where I was saying like the clinical judgment comes in hand, right? So not all our residents are going to have this situation, right? So the ones that we can, the ones that are not weight, like they're weight bearing or they're not like they can move because they had a procedure, those are the resident, right? So this is where we use our clinical judgment. We say we can't touch those residents until they be seen by a PT or whatever. So we're gonna wait on those. That's fine with me as long as we get it the next day in the morning when they are like okay to get weights. But those residents that are able to, there's no reason for us not to. And I know it's like maybe one more thing, but it doesn't take that long to give a weight, and it really does help me a lot. And as for the hospital weights, I just came from working at the hospital, and they're terrible. So like I honestly, it's so hard for me to trust their weights. And
again,
sometimes-
Shelley, as you know, it's hard for us, for me, to
Yeah.
trust our weights. So
Right.
I'm just saying. I'm being serious.
Yeah, I understand.
Given that we have a scale problem,
Right.
given that, and this kind of ties in with what Pam was just saying and what I was gonna address to the nursing staff. Next 3 months is going to be hellaciously chaotic. Any other time, I would say, sure, Shelley, we'll try to do it. Next 3 months, because we've been given a mandate, we're going to be bringing in admissions. We may have up to 4 or 5 admissions. I don't wanna promise you something like, okay, I will make my nurses know, when I know darn well that we may not be able to do it. Give us some time. Of course, we'll try to figure it out, but I don't wanna say, yeah, that sounds like a great idea. Okay, nurses, do your admissions weight.
Yeah.
Don't wanna do that. I like to be more realistic. And I'm not, because this is what I wanna tell my nurses. Next 3 months is really important. We're having this pilot program where we have an admissions nurse, admission coordinator, whatever you wanna call what he's doing right now, all right? We'd love to bring in patients and stuff like that. We're trying to hit 53, which in my opinion is going to be very difficult, especially because of the enhanced precautions and stuff like that, cohorting. We may not be able to make it, but I want us to be able to make it because I do believe in this facility. I do believe that administration does want to do the right thing, but at the end of the day, this is also a business, right? And they want that census up, all right? So we have, bringing all these people, and I know it's gonna be hard on all of us, like all of us, because I can see a day when we're getting like 5 admissions and everybody's going to be losing their minds.
It's almost impossible
All
for
right.
one person to get that done.
I know, that's why we need to all jump in. We just will have to all jump in.
There's what I'm worried about is errors.
I know.
Because it's happening
I am
now.
too, I am too.
Certain people are doing
But,
it, so-
at some point,
Yeah.
you've gotta just say, okay, I've been hearing about this, I've been hearing about this, I've been hearing about this,
The liabilities.
the census and stuff like that. If you feel like, especially for, the resource nurses, if you feel like it is getting unsafe, all right? You've just gotta call me, Alexis, John, Sam to help. You've got to. And please, floor nurses, help the resource nurses, because a lot of these things are just tedious stuff.
It's just all details.
It's just baseline care plans. It's like baseline orders, okay? I
But there's so
know
many
everybody's.
details to each admission. If we could cut down the admission process, then it would be doable. But as it is now, sometimes it takes me
The
4 to 6
admission,
hours.
I understand,
Just to
but
do
the
one
admissions
correctly.
process
Yeah.
is tied to what we need
Yeah.
to show as
Yeah.
far as, you know.
Increasing our census.
No,
No.
the reason why we're doing the things that we're doing and opening up the things we're opening up is because it's based on regulations. So that if we don't do that, then the surveyors are gonna ding us. Believe you
We
me,
have to
I
do
would
everything.
love to have them just come in and we take down their name and that's it, they're admitted. Would love it, would love it. Yeah, no, I would love it if we could just put in their med orders and that's it.
No, just a shorter
Right.
process.
Right.
A shorter process.
But, you know, it's just, we can't, it seems like every time we turn around, the state is saying they need this and they need the care plan with the IDT, with the, you know, all these other people, they're adding more and more and more. It was not like this when I first started.
Yeah, I
It
know.
was not.
I know, it's changed.
It's
Yeah.
changed
Yeah.
a lot, and it's just, but anyway, I don't wanna scare you guys, but I want to let you guys know, this is what may happen. And you know, especially Sandy, since you were looking at Eason, there will be days when we may not have any admissions because it's just dry.
Sure.
It's those days I want you guys to really try to pull together and get things done like what Shelley wants, what we all want,
Sure.
right?
Yeah.
Get those care plans updated, just, and I so believe in this place and I think we can be like, we are excellent. We are excellent. And it's not because, you know, we have like the most experience or this or that or whatever, but I genuinely believe that almost everybody who works here, we genuinely love our residents, our population, and we, you know, even when we want to just like wring somebody's neck, we're adults, we're professionals, and I just really am grateful to all of you guys. But don't ever let it be said, I didn't warn you, it's going to be hellacious the next 3 months. This is what I told the nurses this morning. Because it's gonna be hellacious, you guys are gonna get stressed out, all right? Don't let it just fester. Come to me, scream, and I will say, I told you, suck it up, shut up. It's just 3 months, and then of course I'm probably lying and it's gonna keep going on because you know how it is, to keep it at a certain level, we have to keep churning.
Yeah.
And you know, you
Yeah.
saw, we had to send out 2 people
I know,
yesterday.
I sent out 2 911. I sent out
So,
2 of them,
I mean,
yeah.
we
And we're gonna
admit
get a lot more
one, get-
send-outs too, with a lot more rehabbers.
Exactly, because the hospitals are sending them to us, they're like dumping them on
Well,
us,
they're
but,
sick people to begin with.
They are,
You know,
and-
so, yeah.
and I love Pam, everything does
Yeah, yeah.
kind of flow down.
Yeah.
But this is the other thing, I'm going to have a sit down with that administration, and I've already done it. I'm like, you guys have to bring us custodial patients because this Medicare thing is not sustainable. That's why they, I think, finally gave me an admissions coordinator, but that still puts a lot of pressure on us. So, I mean, just
So Ricky's got
slowly,
to-
slowly.
Is Ricky gonna get the admission nurse? Is she gonna actually do the admission or she gonna just?
She needs to do the admission, just the ESIN, because we're trying to figure out, if she has time, because you know how sometimes the ESIN, they don't put anything in.
I always check it.
At that time, and this is the other thing, I hate to tell this to any of the resource nurses, but at some point, because I do want Ricky, especially if we get that many Medicare people, MDS is gonna get hit.
Oh, I know they
So
are.
I need her to kind of help her out as well, so I'm going to change the job description for all resource nurses. We're all gonna have to like configure different responsibilities. I will ask all resource nurses to keep an eye on the ESIN. That'll be another part
Yeah, I've
of
been doing that anyway,
the,
so,
correct.
yeah.
And I really do, thank you, Sandy,
Yeah.
because
I don't have an admission, that's what I
your,
do.
you started that and that kind of showed them that, hey, it sometimes, it might work.
Everybody needs to
So
just dive in.
everybody
Help.
needs to just dive in and help.
Yeah.
Do you have a name now for the commissioners?
No, because she's gonna come up with it, but it's not, I don't want, I think, I was just using admission nurse as a shorthand, but I think people began to think that then she's just gonna actually do the admissions. That's not the purpose. Her purpose, which this is why I always said, they just need to get a nurse in the marketing department, so there's no confusion. But they didn't wanna do that. I mean, I guess they didn't have the budget, or who knows, who cares? But that role is to just bring people in. So, at least for now, and she's learning, at least for now, don't rely on Ricky to do any of the admission.
My own anyway.
Right.
I like to just check them if they've done it all, I can check them and kind of do my own thing with them. that
Right,
way.
but anyways, so it's going to be hard, but we're gonna have fun. We're gonna make it through this. We will, and if we don't. So, but, yeah, but let's, but it's fun, it really will be okay. It will be okay, but at least, my whole point is, let's get it up to 53, which may be impossible, then maybe, you know, I have big plans because I think you guys, like, are the best, you deserve the best. I wanna concentrate on stuff like just, you know, education, just gaining more knowledge, being able to have you guys look at other aspects of nursing, whatever. I mean, there's so much to do, but we, at the very least, we have to get the census out. So, and then there were just a couple of other things I wanted to say. Everybody, I'm assuming that you guys did all of your self whatever,
Oh, yeah, I did mine.
that Paycom thing.
Yeah.
So I'll be meeting with all of you guys over the next couple of months. I think I have until September. And from what I understand, everybody's going to be getting a 3% raise. This is the other thing that I should have brought up to Pam, but I thought it wasn't the right time. So 3% raise, problem. Inflation has been 3.2 as of yesterday. I don't know. I will push for like a cost of living adjustment. I wouldn't hold my breath, okay? So, but I am constantly fighting for you guys. I really am. It's just, you know, and that's also why I'm saying, let's get the census up.
Yeah.
Because if we get the census up,
You can just-
then I can say, pay my staff. It's not, so, yeah, I want that for all of us. And honestly, if you, at any time you feel like it's unsafe, stop, text me. And then I'll say, suck it up.
Suck it up.
What the heck?
Alright.
Shut
Deal.
up.
We need
Deal.
t-shirts, Seacrest Survivor.
She's she's actually that.
Very good.
Huh?
Sorry, I interrupted.
Sorry.
Oh, I'm sorry.
I just wanted to come to,
We still got a lot to cover, sorry.
there's no more misunderstanding. I wanted to just like figure out a solution for the weights. It seems like we kinda just real quick. So it sounds like if they come here later in the afternoon, like 6+, we're gonna wait until the next morning, right? Cause you're saying it's too much for the PM
Well, it's
shift.
feeding time.
Right, okay, I'm
Well,
okay.
Sandy and Satomi are the PM resource
Yeah.
nurses, okay? Are you guys
We
okay
will
with
try.
trying to get,
Yeah.
We'll
like,
try.
say, the
That's-
CHF
yeah.
people?
Oh, sure.
Anybody with
Yeah.
hemodialysis?
Anybody that
Yeah.
is
Yeah.
mobile and like
Yeah.
Miss Plague can walk in here, we'll
Yeah.
do
But
it.
Try to do the
like, I
best.
think at least
We'll
what would
try.
make the goal for like everyone, at
Yeah.
least within like that next day, or if they come in the morning, like that day kind of thing. So like, if we can make that goal, I'm okay with.
Okay.
So.
The only problem that I have with that is that if you don't take it, you better create an order the following day to take the weight the following day.
I always
It's
do
not gonna be
anyway.
taken until the
I
following
always,
week.
yeah,
Yeah.
because the order on the template's not for the next day anyway.
Yeah.
So
So
I can
change the
change
order for
it.
weight
I
the
can change
following
it for
day,
today.
in the morning.
Yeah.
So if you don't do that, your weight's not getting taken.
I always do,
I
so
guarantee-
at
I'm
7
100%
o'clock,
sure on
and
that.
I put RNA,
Yeah.
CNA, I nurse them,
Yep.
so.
No order,
And I
no
put it on
weight
the
taken.
med list, so it won't get missed.
Okay.
Yeah, and then the weekly.
Okay, guys, any questions for the dietitian? I just wanna go over this real quick, guys.
Was
There's
it
a bunch of stuff here.
lost or
I'm gonna go over these
didn't
events
realize
and, observation real quick.
The same.
If there's an event that happened, obviously you can open an event, right? But there's specific things like falls where there is an observation that you gotta open. Okay, falls and also psychotropic meds. Right? There's an observation. There's a consent that you gotta open. It's not really an event, but John wanted me to put that on there. The only event that you need to open an observation for is a fall. Everything else event goes under the event, right? And then John wanted me to put this psychotropic in there. You do have to open an observation. Obviously, there's a lot of situational cases where you do have to open an observation. My thing is that there's a fall. Make sure you're also opening the observation post fall observation. Okay, that's where your CNA statement goes, and it's basically is where you go over the event and try to figure out what caused the fall. Okay. Any questions on this? There's a template right here. It's right in front of the nursing station.
The
You get
psychotropic
confused.
is only for new meds, right? If they've been on Seroquel forever. we don't
Yeah,
have to
yeah,
do
yeah.
it.
This is a consent form.
This is
That
for
like
new-
I really didn't want to put that on there, but that was a question that John wanted me to put on there.
And Joe, one more thing is for Jorinda wants to notify it as and just email
email.
the progress note to Jorinda, and that she always asks.
Or email her.
Email her, yeah,
Email to
copy and
the
paste.
physical
Yeah,
therapist so that way they can do some kind
Even
of
with
evaluation. PT
yeah, it's
eval.
hospice
The
doesn't
room
matter.
change
Yeah.
things is new. We've never done.
Okay, so
an
room
event
change.
for
Here's the thing:
room
was,
changes.
people
Why
get
are
kind of
we doing
confused
that?
why we open an event for a room change.
When they
A room
transfer.
change, especially for somebody who is confused, has dementia, Alzheimer's, they're gonna get really confused. Are they? Remember, we monitor residents to see whether they're adjusting to the room. Are they adjusting to the roommate? So that's the reason for a room change. You open an event, you connect it to the 72-hour, put it in a 24-hour log, and you're monitoring and doing your charting on this and patients that have changed their room. Okay, so simple as that. Anything that you open an event for, it's likely you're gonna have, an order, call the family doctors, yada yada. Those are all kinds of stuff that you gotta do. Okay, so on the next one here, we have Baqsimi. I noticed that on all of our diabetic patients, we don't have this nasal spray for patients that are diabetic. If you're working at night, or if you're working a knock shift and you don't have Baqsimi on there, and somebody is diabetic, bottom out, and then their blood sugar is 10, 15, or 20, and then you can't wake them up, you're not gonna know that you have a PRN order for Baqsimi because we don't have the order. Make sure you're doing admission if somebody's
I always check
diabetic,
it.
that order is being added on. Okay, so Tommy and Sandy, go in there in your diabetic
Yeah, I
order,
always do
there's a
that.
Baqsimi order, and it's nasal spray. If somebody like
Under
bonked out on you,
Oh.
you don't have to find a orange juice or something like that. That's for somebody who's awake. But if you got up too far and this patient is already, comatose, you're not gonna wake them up with the orange juice. Okay. Baqsimi is available in your e-kit, but you can only open it when you have an order on there. Okay. And your nurses on the floor are not gonna know if you don't have an order in there. So make sure. I'm sorry.
Which e-kit is it in?
I didn't even know it was in e-kit. I thought we got it from pharmacy.
Yeah, it's on the e-kit. It's in the.
Is
I
it like
believe
a
the red
glucagon,
e-kit.
right?
Oh, the red.
Oh yeah,
e-kit?
the one that like
narcotic
the IV
e-kit?
or something
Oh,
like that,
the
it might be
IV.
on there.
Okay.
Yeah.
Oh, it's the big
Yeah,
fat
the
red
big
one.
CV one.
Okay.
Gray one, I
What
think
is
it's in
it?
the gray.
So there's
one.
specific
It's
order in there that I
precise.
added. You
Oh.
use it one time,
It's
you call a
not-
doctor,
it's
if
not
you need to use it again, I believe you have to have another order for it. Okay? But it's an important order that we need to have on there. Okay? Alright,
always add it.
also, if you're working on PM, just know that as a resource nurse, you're gonna be the commander in chief or whatever you wanna call it. If there's a fire, you're gonna be the one that's gonna lead the people to all your staff, all your resident to evacuation. Okay, you're gonna do it for a short period because security gonna come in and maintenance is gonna come in, but just know that the initial fire, you're gonna be the incident commander, okay? And everybody else around you is gonna be supporting staff. And that's from independent assisted living, from CATS to assisted living, okay? The same thing when somebody hurts their back. As a resource nurse, or maybe there's no resource nurse and Rosanna is on the floor, right? Somebody comes up to you and they hurt their back, you have to offer them if they wanna go to the hospital, okay? Don't be in between you and the assessment and trying to prevent them from going to the hospital. If they feel like, hey, you know what, I felt I wanna go to the hospital, so you have that option, okay? And we're the only nurses at night, so we are the ones that are gonna determine and do the assessment for these staff. Okay, I'm gonna go over narcotics real quick.
Oh, can I say it and go?
Yeah, go ahead.
Okay. This is for resource nurses. The care plans are not getting down. This is the compliances. I did use one of these forms up front, but it disappears. there are care plans that on the patients since June, they've been here and has not been done. And I know you guys are busy, but these have to be done.
You open them up, you know.
Open them up and do them, because if you don't do them, you can't update them, as she said, you know. And they are still incomplete. We are way out of compliance. There are 9 of them. In the past, Nancy used to do them, and she said, it's not fair for me to do it. Now we have one person doing it, and I don't think it's
But it's a
fair for
full-time
that
job.
person.
It's a full-time job.
If every shift,
Yeah.
one person does 2 of them or 1 of them and mark it off,
Yeah.
it's gonna be done. But the point is when I send it to skilled care nursing or some specific email name on it, it's very obvious that they bypass it. Nobody does them. That's why it hasn't been done. I had this talk this morning with knock shift also. They have to do them too, because Joe is going to monitor these, because they are very, very behind. So please, what I was thinking, I will make a file. I put one of these, I have already highlighted. The first 24 hours, the care plan must start. Don't wait for me to give you guys the care plan. The care plan, I will audit, and I make it easy for everyone. I have the medication with the diagnosis in front of it. Before, you didn't have the diagnosis, you had to go back and forth. Now I have the medication with the diagnosis right in front of it. Just please take care of them. Right now, there's on some of these patients, even the baseline care plan hasn't been done. So we have to catch up. There are some facilities, this morning they were saying they are doing audit on them again, back in Oklahoma. So please, it has to be done. I'm gonna make a file. Every day when I do the audit, I'm gonna put it in the front. Somebody has to do it, and when you do that care plan, 1 or 2, mark it off and leave it in there for the next person. Okay.
There's a folder up there, I made one, it says admission follow-up.
Okay, I mean, if you have done it, that's fine, you can attach one of these to it. This is the first 24 hours. That needs to be done. Please, please.
The baseline care plan can't be there, that's a multidisciplinary.
PTOT
one. We're not
is
allowed to
involved,
finish it. We can do
yeah.
our 1 page, but we're not allowed, it's.
Well, whatever it is,
Yeah,
Sandy,
we're not allowed
care,
it, yeah.
baseline care plan, it hasn't been opened up on
You mean
some
all
of
the
this.
southern or
Yeah,
six,
it has not even been opened
Talking
up.
about that baseline.
That baseline,
Oh, okay.
you know, so,
Not the other one.
you know, and the other ones, you
Of
know,
observation.
you guys, don't wait for me to do the audit, admission audit. You should be able to do it. It has to be done the first 24 hours. This is the compliance.
Yeah.
Some of the residents have already left the seat, and the care plan was not done on them at all. They're gone. So let's take care of these, please. Okay?
And then you have an email, right, that you're sending that out back and
I'm
forth?
sending
Like
it to a
group?
specific email plus skilled care nursing.
Okay.
Apparently, the skilled care nursing is not opening up because everybody bypass it. Because these are not being done.
Well, so we are working on a new position. That brings me to, I'm sorry, you have more? to
No,
add?
no,
Okay.
that's it, please.
We have a new position, not really a new position, it's a position we're trying to fill, which is the resource nurse. We've been trying to do that for, what, 4 or 5 years now? And hopefully, once we can get the hours kind of like, you know, situated, the resource nurse is gonna open up a whole checklist, and that includes care planning. Whatever's not done, it gets pushed over to PM, and then, you know, it kind of snowballs over to the knock shift, and then and starts again the next shift.
Yeah, knock shift,
Okay.
I had a, I mean,
It would be helpful.
we had a talk this morning about that, and they took a copy of that. Now they know that it has to be done by them too. Nobody can bypass it.
Can you put like on the admission article, if there's a black
We have 4 or 5 admissions, I'm like, there's no way we're gonna get.
There- I don't know about the bottom, it's a-
Okay, all right, any questions for the care plan, young lady over here?
Okay.
All right.
He's throwing me out. Bye.
Care plan guru. Okay, let's talk about this most common analgesia, okay, narcotics. In the last 30 days, maybe 3 or 4 weeks, we've had 9 of our full-time nurses involved in med-air, okay, all narcotics, okay? And it was primarily due to hydrocodone or oxycodone, okay? Well, if you're a resource nurse or if you're somebody who's signing off on a medication, you're gonna be part of the med-air. Okay, for example, I go to Zoya. Zoya, I got this Dorco. Can you sign up on this? And maybe I got the 10 instead of 5, right? And I got an order for Norco, but I got Percocet, right? She signs off, hey, you're just as liable as I am. You know what I mean? So that's 2 nurses, right? The problem is that there's so much regulations now on narcotics that I'm almost certain, okay, I'm 100% sure that when they come in on their next survey, they're gonna have 100% focus, all their eyes on narcotics and the documentation. Remember last time they were here, we got in trouble because we didn't put a numerical number on our comments for narcotics, right? That was just a taste of what they're gonna be looking for, okay? So if you gave narcotic at 3 o'clock and it was 10 out of 10, and then Albert comes in and he says it's effective, and you didn't put numerical data in there, they're gonna say, hey, that's wrong, and they're gonna get us a deficiency for that. Okay, so that's how picky they are when it comes to narcotics, psychotropic meds, also infection control. Okay, what Sam is rolling out now, they're gonna be looking all over that as well. Okay, so infection control, and then narcotics and psych meds are gonna be big on their list. All right, let's go over the most common.
I can tell you real quick,
Yes.
we just got a deficiency because
Who's
we
we?
didn't,
We
my
did?
other facility.
Oh, your other facility.
Because we didn't have respiratory rate as something we were documenting in the pain order too.
Oh, yeah.
Just FYI.
You see, there's some new regs that came up, and they're decreasing the amount of narcotics that's being prescribed by doctors. Okay, and you see more tramadol that's being ordered, and you see more Tylenol that's being ordered, and they're trying to get away from all of these narcotics basically. Okay, so let's go over the most common analgesia that's used here at Seacrest or most skilled nursing facility. Okay, and it's compared to hydrocodone and oral morphine. Okay, so when you're looking at hydrocodone and oral morphine, that's the gold standard in terms of pain meds, right? So when you compare aspirin into this category right here, this category, oral morphine, is 360 times stronger than aspirin. Okay, codeine, this category is 10 times stronger than codeine, and this one is 3 times stronger than Demerol. Okay, if you move over here, oxycodone is stronger than oral morphine and stronger than hydrocodone. Okay, oxy is 1.5 times stronger. So if you have an order for Norco and there's no more Norco, and you call the doctor and be like, hey, Dr. Vu, we don't have more hydrocodone. Can we get an order for? And maybe he's sleepy that night. He's like, yeah, go ahead and care. It's 1.5 stronger. Okay, and under oxycodone you have Percocet. Okay, under hydrocodone you have Norco. So just be very careful with that. I know it's not anything significant. It's not something that we don't know. This is something that we know for sure in our heart, right? But because we're so busy, we're moving so fast that the process that we have now, you open a box and there's a Norco order and you pick up the Percocet, it's easily done, right? You're just like, okay, here it is, boom, you get it out. The Pyxis that we're gonna have at the end of this month is gonna hopefully eliminate that error, okay? Also, under this category right here, IV morphine is 3 times stronger than oral morphine. Same thing, Dilaudid here, 5 times stronger than oral morphine. Oxymorphone, and then fentanyl is the strongest man-made narcotic, which is 50 to 100 times stronger. Okay, and then if you look at methadone right here, I don't think we've ever had methadone here, maybe once or twice.
Yeah, we have a patient on it. Yeah.
So okay, so methadone is one of those that's really effective in pain management, but you have to check the heart, you have to get you check the blood. It does as far as efficiency for pain meds. Most of these pain meds right here, their half-life is between 4 to 6 hours. Okay, methadone is long-acting in the blood, not the pill itself. It stays. The half-life is about 30 to 40 hours. Okay, it stays in your system for a very long time, and but it's also the most efficient for pain management because you have 3 pain receptors, right? You have mu, you have delta, you have kappa. It attaches to most of these right here, and it attaches in 2 different ways. There's antagonist and some protagonist that it works on. But it basically is the most efficient way of treating a pain, except that it's also a little bit more dangerous. Okay, so all of these meds right here works in certain parts of these pain receptors. For example, morphine attaches more to the MU right here, and the more you have, the higher doses you have for morphine, the less the increased risk of respiration going down. Okay, and so the respiratory depression goes up, and so, but I'm not sure which of these right here connects to here. I just know that morphine is more predominantly connects to the receptors of the MU right here. Okay, now the Narcan that you have in your EK, if you gave too much morphine, right? And the patient is on hospice, right? Or the patient was on active dying. Maybe you gave IV morphine instead of oral morphine, and now the patient is like not waking up.
Yeah.
Breathing and respiration is 4 per minute. Narcan actually, so if you have a morphine that attaches to pain receptors right here, and it covers the pain receptors, it's gonna have those side effects. Narcan actually kicks out all of that receptors out, and it attaches to all of these receptors. It's a different type of drug, and so it's really efficient, it's really effective in trying to reverse the side effects of narcotics, okay? So make sure that if somebody has narcotics, you have PRN Narcan on there. We have that in our e-kit as well. Just like Baqsimi, okay? This is mostly for our admission nurse, okay, for emergency purposes, right? You have gave too much narcotics, maybe somebody is diabetic, make sure you have those Baqsimi and Narcan in your PRN order, okay? Any questions on that? Let's see, what else is on? Oh, taking breaks, okay? We are just making sure that everybody's taking a break. I know there's admissions that are coming up, but there's something more important than your break, okay? If you're working 6 to 8 hours, before your 5th hour, you should be taking a break. You should take yourself away from the floor. You should go to your car. You should climb the roof underneath the freaking car. I don't care what you do, just get away from the floor, basically. But there's no admission in the world that's gonna tell me I couldn't take a break because I have admission, okay? You can take a break. You have 3 nurses on there, just communicate when you wanna take a break. Take it before the 5th hour. We're really working on the overtime in terms of breaks, okay? Because you have all these nurses, you can get your breaks covered. Unless you have somebody like that's bleeding, has to go to the hospital right away, orders and stuff like that. I'm sorry to tell you, but those can wait. You can take your break. That is state regulated. You have to take your break. Okay, if you're taking a break 6 hours or 7 hours later, eventually it's gonna catch up to us. Okay, and if all of our people are doing that, we're gonna be in big trouble. Okay, so make sure you're taking your breaks. Not only it's overtime, we give you an extra hour every time you miss it by 1 minute. Okay, let's say you're supposed to take a break before the 5th hour and you took it 5 hours and 1 minute later. That's overtime, and we gotta give you an extra 1 hour. Okay, and can't keep doing that. So we gotta make sure we're overlooking our breaks. Okay, all right. Let's see what else is on here. Oh yeah, we had an issue with knock shift. I was trying to mend our relationship between us and the security, because apparently security has been a little bit more abrasive in terms of their communication. So I want to show you, there has been an incident where some of our knock senior has been kind of sleeping. This is not us, okay? This is not us. This is across from here in Gadsden. We have a registry who just fell asleep like a baby right in the middle of everything, right?
You're at home.
All right, and then you can see in the background, there's a patient who has her foot over the thing here, and she's about to fall down, right? She's trying to stand up like this. She's probably snoring, dreaming of, whatever, the beach or whatever. And but if you're working knock or PM, you need to take a break. Take a break at appropriate place. Here, Dr. Mann's office is right there too. You can close that. But there's a break room. There's your car, But don't do it in the hallway. Don't do it in a dining room. I mean, what is that? It doesn't look professional. Family members come in, doesn't look good. All right. I'm also working on some of these signs right here for patients that are fluid restriction or necrotic. Some of these are going to go up in their room. They're like magnets, and so I'm doing some arts and crafts that I'm not very good at. So I'm working on. All right. Any questions so far? I don't have any. See if I went over everything here. Man, we just kind of ran out of time. Anybody has questions on charting or anything like that? Oh, there was an incident on Severino. Okay, there was a fallout, right? There was not one nurse that made a mistake. I feel like the whole facility made a mistake that day. And so much so that we talk about it on our stand-up, and there was orders that wasn't carried out. There was orders that wasn't put in the nurses' notes. There was labs that was overlooked, and everything just kind of fell apart. So I felt like it was a good, a learning process. And so just to kind of, going over the basic stuff. You got an event that happened, call the doctor, call the family, carry your orders, write the nurse's notes, right? Use the 24-hour log, okay? From now here on in, everybody sitting at the front desk has to use the 24-hour. Not only for your, for your communication-wise, because you can leave early if you want, so long as you have all your communication right there. The clerks read it, the nurses read it, and then we communicate from there.
That's helpful for
Okay.
coming in and
So make sure we are covering that care plans and stuff like that. Some nurses ask me how to do care plans. We'll go over that in our next meeting. I don't have enough time right now, but it's quite easy. You know, some of these care planning is quite easy because all of it is in template. Your orders are all in template. All you gotta do is click. Okay. All right. Thank you. If you guys all sign in, we're all done. And then I'll put this post this on video of this on YouTube.